Welcome to part 2 of Diagnostic Pressure. This will focus on clinical reasoning. Let's jump right in.
Medicine is about balancing risk. We frequently think about the risks of an untreated condition or the risks of a proposed therapy. There's another layer to this risk though. What are the odds that we got the diagnosis wrong and offered a therapy with only a risk of harm? Or we incorrectly ruled out a diagnosis and withheld an appropriate therapy? Said another way, how confident would you need to be in a diagnosis of the venous thromboembolism to subject your patient to the risk of anticoagulation? Some commonly accepted diagnostic thresholds for thrombosis are shown here. After clinical assessment, if the risk of clot is less than 2%, then anticoagulation is not warranted as the clot is unlikely to be present, and the odds of giving anticoagulation and causing a complication when a person didn't have a clot to begin with is more likely than there being an undiagnosed clot. Conversely, 85% confidence that a clot truly exists is the generally accepted diagnostic threshold to warrant initiation of anticoagulation because the risk of the untreated clot is greater than the risk of anticoagulating a false positive. So what does this mean in practice? It means that the goal of the history, physical exam, and investigations and point-of-care ultrasound are to get you to a confidence of less than 2% or greater than 85% in order to make a management decision. Pocus can be very helpful here. Take this case for instance. We have a gentleman who is on neoadjuvant chemotherapy for colon cancer. He presents with a week-long history of a painful left leg that's swollen and red. When you examine him, his calf is larger on the symptomatic side. To get the ball rolling, let's just say 20% of patients who present with symptoms of a DVT have one. We then apply the Wells score, in this case, which would be 3, or high risk. This brings the odds of our patient having a DVT to about 50%. That's not strong enough to be actionable. Hence, the standard of care is to proceed with a diagnostic ultrasound before we initiate therapy. But what if you don't have access to this? It's late at night, you're in a smaller center, or a myriad of other technical reasons. You could empirically anticoagulate until imaging is available, but then you run the risk of unnecessarily anticoagulating a patient with gastrointestinal cancer who's on chemotherapy who may just have cellulitis. Can pocus help you make a safe decision? Absolutely. You don't have to look very hard to find evidence for shockingly high sensitivities and specificities for pocus for DVT. If you apply these numbers, wow, that certainly meets the diagnostic threshold. But what if your exam didn't go as planned? What if there was some artifact or some uncertainty, or you don't do this exam on a regular basis? Your likelihood ratio may only be 5, way less than 30. Well, in that case, back into Bayesian limbo we go. Pocus is rarely done under standardized conditions. That's the point. It's done at the bedside. This means that the accuracy will be confounded by a myriad of factors that will be unique to each patient assessment and each operator. This is why a point-of-care scan will never replace the standard of care in diagnostic imaging for this indication. Even if your findings agree with your prediction, your patient still needs a comprehensive scan. The gold standard not only confirms your finding, but also provides additional clot characterization and complication screening that could be beneficial to them down the road. Having said that, when you have a high-risk patient with a positive scan, it is reasonable to start treatment while you wait for a comprehensive scan as long as they have an acceptable bleeding risk. There is very good evidence that pocus reduces the time to diagnosis and the time to initiation of treatment for DVTs. I would also argue that the extra few minutes at the bedside performing point-of-care ultrasounds improves patient care in ways that are much too subtle to be measured at this point. Another situation to consider is if the illness script and the pocus findings are discordant. For example, you suspect a DVT, but you cannot see one with pocus. As you can see, you're back into Bayesian limbo and cannot rule out a clot definitively. Depending on the context, you may or may not give a short-term anticoagulation until definitive imaging can be performed. I mention this to emphasize the importance of the clinical assessment. Pocus is a powerful tool, but not powerful enough to replace the other tools in your toolbox. Finally, be humble and avoid ghost scanning. Good practice is to archive your images and have a system of quality assurance, especially when you're making diagnoses with major implications for your patients.
So here's our patient. He had a very high well score, and this clip was taken from his left popliteal fossa. You can see that the popliteal vein is not compressible. This is very likely an acute symptomatic DVT, and since he is at an average risk of bleeding, it is reasonable in this context to start anticoagulation while awaiting the comprehensive study.
The pocus exam for DVT is technically challenging, but of tremendous value to clinicians who are able to carefully assess patients. In the right hands, pocus can assist by expediting the time to treatment for high-risk patients with DVT and safely defer therapy in low-risk patients while awaiting definitive imaging. Pocus should never be used as the definitive test for DVT, but it sure can be helpful in the interim. I hope you found this talk helpful, and I would appreciate thoughts and feedback as I endeavor into other projects. Once again, I would like to thank Dr. Brian Buchanan and Alberta Sono for their support with this project. Happy scanning.